had a knee problem that just didn't respond to any physical therapy, and I ended up having a knee injection and two knee scopes, and I just was pretty miserable.
Well, hey, Tony, how are you?
I'm great. Very glad to be here. Thank you.
Yeah, thanks for coming on. I'd love to sit and talk with you about foot health and feet and what we can do to improve just the function about on our feet. And, like you said, everybody's got feet. So even if you don't have foot pain or foot dysfunction, this will hopefully help out. Before we dive in, just tell us a little bit about yourself, your background, and then why you're into feet.
Okay. All right. Sure. So I'm a physical therapist. I graduated from the Army Baylor physical therapy program in 1992 and had a knee problem. I was in the Army, required to run, and all that kind of stuff, but I had a knee problem that just didn't respond to any physical therapy. And I ended up having a knee injection and two knee scopes, and I just was pretty miserable. And I went to a course that taught about 8 hours on biomechanics, and I realized two things. One, I didn't know biomechanics. I didn't know biomechanics of walking, which was pretty bizarre considering that's a big part of our profession.
Yeah.
And in the Army, soldiers eventually get from point A to point B by walking, right? How can we not understand as something as integral as walking? And then I also thought that that's why my knee's not getting any better. So the same guy offered a 3-day training, which I took, and really started filling in a lot of the gaps for me. And then was in a really good location for continuing ed in San Antonio. So I went to a podiatry 3-day continuing ed. And then I went out to California for a course on how to actually make orthotics. And then came back to San Antonio, a big medical center that had a huge orthotic and prosthetic lab. So I had the opportunity to practice all these techniques and with an endless number of patients with essentially, free materials to practice on. And that's basically how I got my start. And then I ended up making a 2-day continuing education course on foot and ankle biomechanics and interventions, which is called Thinking on Your Feet, and rewrote 32 hours of curriculum at Baylor.
Oh, holy
And that
smokes.
was, yeah. And so I've been teaching this course basically for, I would say, 25 years.
Okay, awesome. So you know your way around a foot.
Yes.
And I've seen a bunch of your videos on YouTube. So you do a pretty in-depth analysis of, hip problems being linked to the foot or the ankle and
Oh,
all that kind
sure.
of stuff. It's fascinating stuff. And it
Yep.
is one of those things that, you know, many people think, okay, I've got knee pain or I've got back pain or I've got hip pain, and that's where they're focusing their problems. And even clinicians, right? Like, you've got knee
Sure.
pain, we're going to look at your knee, we're going to try to fix your knee. But
Yep.
this kind of expands your vision a little bit to say, okay, let's look up and down the kinetic chain and see what might be affecting,
Exactly.
everything, right?
Yeah. On the second day of the course I teach, we have real life patients come in for the exam and intervention, and the attendees of the course are not allowed to ask the patient where their symptoms are.
Oh,
Right?
okay.
We get so focused on symptoms that we can lose sight of the pathology. And that's why a lot of these patients are frustrated with physical therapists. Well, I've tried physical therapy. I've tried, you know, maybe several times, but it's the same intervention that's overly focused on the symptoms, and they've failed to even determine the cause of the pathology.
Yeah. Yeah. No, I'm sure that's super frustrating. So diving in then, when we talk about foot, foot health and feet function, like, let's just baseline level. What do we mean when we say foot health?
Okay. Well, I feel like what that term means is that the foot has a very important job to do. when your foot first makes contact with the ground, your foot needs to be able to accommodate to any surface, any canted or unlevel surface. And then your foot needs to become a vaulting lever, and it has to make that transition at the right time. It can't be a vaulting lever when you land, and it can't still be adapting to the surface when you're trying to leave,
Yeah.
when you're finishing your stride. And so foot health means the ability of the foot to make those transitions, because when it doesn't, it increases the workload on all your dynamic and static stabilizers. And if your foot is failing to finish its work, guess what? The hip is the next joint that moves in the same three planes of motion. And so then your hip is doing all this extra work, which is bad news for your lumbar spine and your SI joint and your lateral hip structures. But all that work that the hip is doing has to be conveyed through the knee. And so that can affect your knee. And so
Yeah.
I would say good foot health is when the foot's able to do its own work.
Okay. And what kind of things are we looking at? Is it strength? Is it range of motion? Is it both? Are there specific muscles or movements in particular that really determine, okay, this foot is, maybe it's not at 100%, but it's adequate, it's functioning, right?
Right. I would say it's a little bit of everything, right? There certainly is strength necessary in your dynamic stabilizers, and if you want to, we can name those off. Range of motion is critically important in the ankle joint and the first MTP joint specifically, but it's more about physics, right? You can be enormously strong, but if your leverage is poor, it doesn't matter.
Yeah.
And in the foot, leverage is huge, and because these joint axes and these vectors have tremendous leverage if the foot's in the correct alignment. And if the foot's not in the correct alignment, they sometimes can't function to stabilize the structure they're supposed to support.
Yeah. Yeah. So then what are the most common or frequent dysfunctions or problems that people experience from maybe let's say it is bad alignment when they're stepping? Is it the way their foot is hitting the ground? We hear a lot about, heel striking during running, or forefoot or midfoot strike. And I'm sure the same thing is there when we're walking as well, where our foot lands, how it touches, and where it rotates all affects that, right? So when we're specifically talking about foot function, what are the biggest dysfunctions or problems people experience in their feet that kind of
Right.
causes problems all the way up and down the chain?
Sure. Well, initial contact, right, is a challenge. If you don't have initial contact on the right part of the foot, you're going to have symptoms. But a lot of times that stems from how you finish your stride on the opposite foot. If you don't finish your stride correctly on the opposite foot, you're almost doomed to have a bad initial contact on the landing foot.
Yeah, you're
And
just kind of
so,
landing wherever you left from, right?
yeah, because if the say your right foot, you're having to abort your stride early, the left foot has to land early unless you're, levitating, and not too many of my patients are very good at that.
Yeah,
And so that's the challenge, and that's why we get so focused on the symptoms on the left leg, and we've missed the fact that the reason we're having these symptoms on the left leg is because the right leg is unable to finish its stride. And that is usually an instability within the front part of the foot, where that metatarsal or that transverse arch has collapsed. And when that happens, you lose the ability to have a forefoot rocker, where you go from terminal stance to pre swing. It just doesn't happen. And if you lose that portion of your stride, you lose a lot of the energy return mechanisms within the foot from the utilizing the plantar fascia as the Spanish windlass. And so that creates a lot of extra work of the dynamic stabilizers on the failing leg, and then on the leg that you're making that abrupt initial contact, that can sometimes be a bad starting point.
Yeah. So where are people landing then if they're, let's say they're cutting their right leg short, they're landing on their left foot early, where are they typically landing then that's causing that dysfunction? Is it more on the heel? Is it more on the toe? Or is it kind of just
Hmm.
flat?
Right. So yeah, that would be a worst case scenario. You're supposed to make initial contact in walking on your heel, on the outside of your heel, on the posterior side, on the back side of the heel. And so that is not what's going to happen if your right foot is failing. You're going to land further into your stride. So it's going to be more distal calcaneus.
Yeah.
Hopefully it's still lateral, but sometimes it's middle or medial. And then, the next level of failure is where you just kind of land with the whole foot
Kind
crashing
of just
down.
flat. Bam,
Yes.
right?
Yeah. That's called initial contact and loading response. And that means that your foot is doomed through the mid tarsal joints to be unstable throughout the whole stance phase. So if your mid tarsal joints are unstable, all your dynamic stabilizers are just screaming, right? The muscles of your foot, your calf muscle, your thigh muscle, your lateral hip muscles, all those muscles are trying to keep you from falling off of an unstable foot, basically, or keeping the unstable foot from sliding out from under the body in a manner of speaking.
Yeah. Well, and does that cause any like deformities or dysfunctions in the feet themselves, like flat
Sure.
footedness, or is that more of
Yeah.
flat footedness results in some of these problems, or is it kind of both? It could be one or the other.
Well, flat footedness, you can have a flat foot that's still functional.
Yeah.
Uh, Generally speaking, a flat foot is a hypermobile foot. And so that could be just an accessory finding, or it could be part of the problem. What happens is the further medial your initial contact is, the more unstable your mid-tarsal joint is, the more you start to sublux these long flexor tendons, flexor hallucis longus, flexor digitorum longus. And when that happens, they start to bowstring, and you get things like hallux abductor valgus and clawing and hammering of 2, 3, and 4.
Yeah. Okay. Um, let's say somebody's got what we were just laying out. They're striking a little early, they're striking a little late. Um, are there any specific exercises or stretches even that we would give somebody that somebody could do to try to improve their gait, or is it all being mindful? Maybe the exercise is being mindful as you're walking.
Well, you could try that, right? You can certainly be mindful of walking, but walking is an autonomic
Yeah.
type of activity. And walking is very unpredictable, right? If you're just walking down the street going for a walk, you could be mindful. If you're walking around your house and you take 4 steps and turn, and 6 steps and pivot, and 7 steps and top and stop and start again, if you're walking around your house like that, you can't be mindful. You're doing too many other
Yeah.
things,
You're picking up
right? And
toys, you're
that's,
trying to avoid dishes.
yeah, and that's most of our walking, right? Most of our walking are in offices or homes. We're walking in these boxes. That's not how we're designed to move. But you certainly, I don't think, can be mindful of walking if that's where you're spending all your time walking. And so I don't think you can exercise some of these things out. I think sometimes they're coping strategies, and I describe it to patients as I said, if you're a great card player, but you were dealt bad cards, there's only so much you can do with those cards. And I think for most of us, when we're walking, our body's doing the best it can. It's using the cards it's been dealt. It's had decades to practice playing with these cards. It's playing with them the most efficient way that it can. And it doesn't mean that it's not creating pathology, but that's the best it can do. And if we're super mindful, we can move that needle maybe even 25%. But as soon as we, pick up the vacuum or we're doing something like that, we lose our mindfulness, and then we're right back into
Yeah.
that pathological gait pattern.
Yeah. So then what kind of adaptations are we looking at? Is it taping or orthotics or Funny
It
shoes.
might be, yeah, oftentimes it's just shoes, right? Oftentimes we just need to choose a better shoe. If the problem is within the front part of the foot, there's really no shoe that supports that very well. Um, and so, yeah, then we need to use things like tape or orthotics. In the course I teach, I teach participants how to make orthotics out of orthopedic felt. When I was deployed, that's all I had. I made orthotics out of orthopedic felt. You can make a super easy and effective orthotic out of felt that will immediately help a patient move better and reduce their symptoms too immediately. And tape is can also I teach taping techniques in the course. The problem with taping techniques is eventually it's hard on the skin,
Yeah.
right? And so what whereas the orthotic is obviously not. The advantage of the orthotic is it just instantly changes the physics of the whole situation. And that you can't do that with any exercise. You can't do that with taping, but you can instantly change physics with an orthotic, and sometimes it can be um, absolutely stunning how much a little change of physics can change the whole gait cycle and their symptoms.
Yeah. Is there any concern about, um, I guess, long-term orthotic use? Like I know splinting the wrist or something like that, we try to avoid, 6 or 8 weeks tops while the ligaments heal, and then we're trying to remove it, and we don't want to get increased laxity or something like that, or incidental laxity from using a brace for too long. Does that not? We don't really worry about that with the foot all that much because, like you said, we're not changing those patterns over time. Or is the orthotic something we use kind of as like a training wheels, if you would, to get up to doing normal gait patterns or typical gait patterns or something like that?
Potentially, I would say in the patients I see, their physics are so awful that they're never just going to be better, right? But I don't see a typical patient load either. I see the patients that have been dealing with things sometimes for
For years,
decades.
yeah.
Yeah. So I would say you might be able to wean out of the orthotics. I think, I keep, talking about my course, obviously, because I feel like there's great value to it. But
Yeah.
I think if you took the course, you'd have a understanding of the people who may do okay short-term orthotic and the ones who are probably going to need one for the rest of their life. Now, the other thing, I teach how to make the orthotic out of felt. That's not a very obstructive device, right? It's
Yeah.
felt. And so the orthotics that I make in my practice are, they're not rigid. I do not believe in a rigid splint like orthotic. So I don't like the graphite or the whole moldable
Like
hard
thermoplastic or something like
plastics.
that.
Yep.
Yeah.
Yeah, your foot is supposed to change shape when you walk, and you can't just hold it in a splinted position and think that's much better for the body than what it was dealing with before. So I think you can use a pretty soft material that isn't super confining to the foot and what the foot needs to do that can still make a huge difference.
Yeah. Yeah, it's funny. We hear a little bit about, barefoot running. It's still kind of making its way in the running world. And there are
Yep.
people that kind of fall on either we need super supportive stuff, rigid stuff to keep our feet stable and secure. And then there are people on the other end of the spectrum that are like, oh no, all of that is evil. We should be running around barefoot because that's the way we were we were designed. And what I'm hearing from you is it's probably somewhere a little bit in the middle, right?
It's exactly in the middle. Yeah, if you look at a lot of those barefoot studies and the cultures of people who are barefoot, one, they're not very big humans, right? The man is around 150 and the lady might be around 115. They're not very big humans. And number two, they live without a shoe their whole life. They just didn't decide, in their 30s that they're going to start being a minimalist or a barefoot runner. And they don't walk around in boxes, right? We walk around in boxes all day long. It's so bad for our bodies. They're out, they're moving, they're on uneven ground, they're on level ground, but they're not walking around in boxes like we do. So I would say you can't really just say that everyone should be barefoot when, I think you wouldn't find very many people, say 250 pounds or heavier, who are long term successfully barefoot or
Yeah.
minimalist. I think it's probably going to catch up with them.
Yeah. Well, and part of that is just because of the weight on the arch of the foot, or is it the way the weight changes the mechanics, or both, or
Well, it's physics, right? And so the heavier the patient is, the more essential physics become. If you're say 110-pound female, I have a really good friend who's a minimalist, and she probably weighs somewhere between 110 and 120, and her foot is super muscular. It looks super. You can see all the muscles in her foot, right? But she's able to handle potentially bad physics with strength because she's not dealing with that many forces. And
yeah,
here's the other thing about running: running's a skill. You can get better at running. You can get running coaching. You can really improve your stride and be a minimalist as a runner. Whereas when you're walking around your home and office, you got no business being a minimalist
yeah,
because it's too unpredictable. It's too hard on your foot. Whereas, you go for a run and everything's fairly predictable on a run.
yeah. All right. I think that was our big question, the minimalist trend.
Yeah. No, I get that question in every class. And certainly you'll understand it. If you truly understand the foot physics, and then that question comes up in class, everyone in the class, there's no one who's shaking their head no. Like, they all get it. It's just physics. It makes perfect sense.
Yeah. Can't argue with the science, right?
Yeah.
Well, thanks so much for taking the time, Tony. If there's just one or two main points that you would want someone, maybe it's somebody with foot pain or knee pain or something like that, they know they've got a problem with their feet. One or two main points you'd want them to walk away with from today, what would they be?
I would say you can't get number one, you just can't get overly focused on your symptoms, because the
Yeah.
pathology might be in the different limb. And if you're not getting better, there's a reason why. And it's usually wrong diagnosis or wrong treatment. And I would say the other thing is, you can look at my YouTube channel, is also called Thinking on Your Feet. I put a ton of material on social media. I'm just trying to, I hope, elevate our whole profession to recognize these things. And patients can contact me, and I can hook them up with a therapist who's taken my training in their area, or can send me video. Any therapist can send me video of their patient walking barefoot on a treadmill, and I'll just tell them what I see and what I suggest in regards to intervention. So I really try to, and I don't charge anything for that. I just try to put as much out there as possible to try to further the education, and it elevates our whole profession if we're
Yeah.
problem solvers instead of symptom treaters.
Yeah. No, that's great. Well, thanks so much. I'll get all of the links for you and I'll put them in the show notes. That way people can find the YouTube, they can find the Thinking on Your Feet course, and then we'll kind of go from there. So thanks so much, Tony.
All right, sir. Appreciate it. Have a great day.
You too.